Good afternoon, dear colleagues. We are ready to continue the work of our forum, and we are opening a session. There are not too many people in the audience, but there are 800 people with us watching us online, and I'm happy to welcome you here and to start the session that is called Sustainable Development Goals Rehabilitation 2030 Global and National Experience. The first speech is by Dr. Sergey Savashinsky, who will tell us about the organization of cooperation at the global and regional levels in order to implement the Sustainable Development Goals. Dr. Sergey Savashinsky.
Dear colleagues, dear moderator, thank you very much for this invitation and an opportunity to speak. Today we have quite a challenging task. So I am supposed to speak about cooperation among former Soviet countries. And I am about to speak about the fundamentals of this cooperation and their principles before Mr. Mishkov and Sergei Cherkasov and other participants like Nelly DeWeber will speak. They are all doctors of medical science.
They will develop my topic further, and I think if the audience has the questions after my speech, it's better to leave them till the end of the session, because I think that my colleagues will answer the most part of them. Yes, sure. Christina is looking after the chat that we have in our online translation, and we will take care of the questions. Okay, thank you. So, the title of my speech is Bioethic and the Principles of Creation of National Evidence Base in Healthcare in the CIS countries to reach the Sustainable Development Goals. Today we will speak about our collaboration in framework of the third and the fourth Sustainable Development Goals, that are the healthcare and the education. Why have I called my speech like this? I would like to tell you that on the 23rd of November last year, during the 75th anniversary session of the General Assembly of the United Nations, they signed the resolution about the cooperation between CIS organization and the UN. This resolution launched the beginning of the process of legitimation of such a regional structure as the Commonwealth of Independent States, or CIS. And if we look closely, what is this resolution like and what is described in it? We will see all the aspects of the life, but what is the most important? Some of the points describe the wish to develop the further collaboration in framework of the existing institutions of the UN and other projects that are ongoing in the UN activity. As you and I know perfectly well, that the main institutions of the UN are the World Health Organization, the WHO that coordinates the activity of the state members in healthcare, and the UNESCO that coordinates the activity in culture, science and education. As our healthcare, scientific activity and education are inextricably connected among each other, today we will speak about this structure, about the creation of collaboration from the point of view of the resolution, from the point of view of the institutions that work on the territory of the post-Soviet space countries, and how we see all these aspects, what we have done already and what we are going to do further. I would like to tell you that on the territory of the post-Soviet space there are such organizations as Eurasian Economic Community or EAEC and the Union of Russia and Belarus. If you look at this from the point of view of the work activity and CIS and EAEC and other organizations, we will see that the huge steps have been taken over the decades. For example, if we speak about CIS, I just would like to remind you that there are two main structures in CIS. They are the Executive Committee of the CIS and the Interparliamentary Assembly of Member Nations of the CIS. The Interparliamentary Assembly was created for lawmaking and legislative activities. The Executive Committee contains bodies that bring into action the projects and directions that were approved by the member nations. I would like to tell you that for almost 30 years of the history to the present, about 200 legislative acts of model laws have been developed in the Interparliamentary Assembly. They were developed in energetics, house building, and in those sectors without which it's impossible for the member nations of the CIS to live in the world and among each other. In framework of the Interparliamentary Assembly, next year we will celebrate 10-year anniversary of the Expert Committee in Healthcare of the Interparliamentary Assembly. Different events and meetings are held within this committee. Moreover, it conducts huge work on lawmaking activity in healthcare. I will speak about it a little bit later.
Brief, if we take a look at sustainable development goals, SDGs, we can say that arrangement of cooperation at global levels ensures the following. First of all, a possibility to get each country involved by means of resources that each particular country can allocate. There is no need to explain that because economic development of the countries is so varied that, of course, it is impossible to see the same contribution from each country. Moreover, it ensures full-fledged integration of solutions for different member states, as well as acceleration of development and introduction of technologies and other factors. If we go back into our history, starting from 1991, all the countries in the former Soviet group have identical trajectories. But anyway, our common history is something that they share, and the stages that we went through together and our language, our culture shows that we in these countries, despite the post-Soviet period of 30 years, we need to understand clearly that we have very close, similar political, economic, and social and historical specificities, particularities. The region, CIS in particular, is a region whose members have very similar mortality patterns, and development of medical technologies, management technologies, information technologies show also very linked patterns in these countries. We live next to each other, we're neighbors, and changes in economic systems are very akin to each other, and social changes as well. Social changes starting from 1991 are also similar, and this pathways, these trajectories in these countries are very similar. Everyone knows what is happening in the neighboring country, and the economies are interlinked, and there are very similar implications. Speaking about SDGs, our Eurasian cooperation among former Soviet states can ensure the following in terms of improving public health. First of all, to enhance national health in CIS countries and Eurasian Economic Community countries. It will help ensure maximum effective development and evaluation and rollout of contemporary technologies in healthcare, as well as build appropriate systems for healthcare and training qualified staff, take effective solutions and apply technologies and ensure rational use of healthcare resources. It will also help carry out joint projects in order to minimize expenses and improve their results based on overall general global achievements and a focus, consideration for regional particularities, regional features. I will speak for a couple of times about this slide, and dear colleagues, I would like to tell you about the cooperation in the areas that we are covering as part of our session, and then I will move on. We started working in 2009. In 2012, an expert council under the Interparliamentary Assembly was set up. Starting from 2012, there was a project on developing new clinical recommendations in the territories of CIS states, and it is for more than 3 years that this project has existed in a form in which it exists now. And I'm chair of the board of the Council for Developing Recommendations. So I will cover the structure of this entity a little bit later. But first, I will start with the evidence base of healthcare. It is a great pleasure for me to speak as part of this Congress, and this topic is very close to me. I have been involved in the social insurance fund of the Russian Federation and dealing with the rehabilitation of the vulnerable groups, those who had occupational vulnerabilities, and without evidence basis, no prevention, no diagnosis, and no treatment, and no rehabilitation is possible. I'm struggling to use this clicker.
Нашел. Извините.
Here it is. It's working now. So, dear colleagues, I would like to pay your attention to this set of blocks, which states preclinical trials, clinical trials, systemic analysis, evaluation of technologies, and so on and so forth. Together with experts, we work in partnership with the WHO, with UNESCO, and our partner is Intergovernmental Committee on Human Rights and Bioethics under UNESCO, um, International Bureau on Clinical Recommendations, Cochrane community as well. You know that this is the main organization that is involved in evidence-based medicine, and it accumulates evidential results of clinical trials in particular that are further used in healthcare. And it's occurring European clinical research institution, which is our partner, and Craig as well. These are all our partners and experts, organizations, and the main leaders in terms of cooperation between national and international experts. I would like to pay your attention to the fact that preclinical trials that after 1991, for the reason of politics and economy and the Soviet system's collapse. So after that, and I will not go into depths, but I can say that preclinical trials today in former Soviet countries are performed only to some extent, to some fragmentary extent, based on the orders of international companies or universities through grants. But so far, there has been no unified single system across the countries. I would like to focus your attention on the fact that preclinical trials constitute an expensive type of trials. And in pharmaceutics, there is a trend which is as follows. If we look at 2012, so as to introduce some medicine at the regional level, you had to spend 10 to 15 years and 1,300,000,000 euros, dollars rather, US dollars. And right now, as of 2019, the terms, the periods are the same, and the money that you need to spend is as high as $2,300,000,000. So you can see that from the financial point of view, you cannot do without cooperation in the matter of preclinical trials. And as far as organization of preclinical trials in former Soviet countries is concerned, we can say that there is a lack of correlation with clinical trials. As far as clinical trials are concerned, we see another substantial challenge here. In post-Soviet countries, clinical trials are performed for the purpose of registration of a new medicine or to extend the scope of indications. All clinical trials in post-Soviet states are not a part of Cochrane library and are neither covered by Creek or other databases due to their level of research. So we need to understand that without enhancing the level of clinical trials, we cannot move forward, and we need a body of evidence for that. We need evidentiary basis. So independent clinical trials that are performed in many developed countries can also be discussed, but I don't want to focus your attention on them. I want to skip them and move forward to clinical recommendations and systems analysis. So as to prepare one clinical recommendation for a specific issue, a group of 15 to 20 people will spend from 2.5 to 3 years on this work. And this group uses a systemic analysis of clinical trials using a body of knowledge, evidentiary basis of a specific issue. And if we speak about national clinical recommendations, we can say that without clinical trials based on a body of evidence, we cannot perform systemic analysis of these clinical trials, and we cannot prepare a clinical recommendation with a strict and clear evidentiary basis. So this is a problem that has been in the spotlight for the last years. So now moving to the question of healthcare evaluation, I can say that there is a specific point here, and many people mix up the concept of clinical recommendations and evaluation of healthcare technologies. Many leaders, opinion leaders in former Soviet states say that when clinical recommendations are devised, we use healthcare evaluation technologies, and we need to forget about that once and for all, because clinical recommendations are documents that just do not give the order of actions in a specific case, depending on the qualification, but they are also prepared from the point of view of positive or negative clinical experience, while healthcare technology evaluation is evaluation of economic effectiveness of a specific method from the point of view of a region, from the point of view of the country as a whole. I want to also say that we cannot but note that our colleagues from Kazakhstan are the only one among former Soviet states who managed on the 19th of May, 2 years ago, to issue a decree on the evaluation of healthcare technologies in different institutions of different levels in their country. Healthcare management technology evaluation can also be discussed endlessly. There is a serious debate almost in all former Soviet states regarding the need of obligatory medical insurance. We know that there has been a debate about compulsory medical insurance, whether it needs to be or it doesn't need to be. We understand that healthcare management technology evaluation will be always linked to this debate. In the Russian Federation, there is an extensive experience in medical insurance, voluntary medical insurance. So there is positive or negative experience as well. And the focus of Kazakhstan on medical and social insurance, as we see it, is quite constructive and substantial, but still without cooperation in this area, in the evaluation of healthcare management technologies, we just cannot do. We cannot do without this cooperation. And another aspect is evaluation of healthcare quality. 2 minutes, you've got 2 minutes. Can I have 3 at least, or 4? Because 2 is not enough. Okay. Everything that I spoke about regarding preclinical and clinical trials and so on and so forth have to become the quintessence of healthcare issues and evaluation of healthcare quality. I will not go into detail, but as far as healthcare quality is concerned, here we also have a number of challenges and problems. So why did I identify all these particular fields, all these particular areas, if we do not affect the legislation, the regulatory framework of our countries,
then it is useless to speak about any kind of activity, whether they are disease prevention, diagnostics, treatment, or rehabilitation. Therefore, as the basis of our activity, we took the change of the legislation. What do we have today? We have the full analysis of all legislation systems of the member nations of the CIS in preclinical studies and 70% readiness of methodical guidelines for preclinical studies in the post-Soviet space. Moreover, we have 100% analysis of the clinical studies and 95% readiness of the guidelines for the clinical studies. In the system analysis and clinical guidelines, we have been working on the model law on the clinical guidelines for more than 3 years already. And on the 29th of April, we sent it to all the governments of the CIS countries after a long process of confirmation. Speaking about the assessment of the technology of the healthcare, we have 70% readiness of methodological guidelines, and Dmitry Olegovich will speak about it today. Speaking about the assessment of the quality of the health services, I can say that we have a lot of work to do in different fields, in different nosologies. And for example, diabetes is the priority in our project, and we have done the 50% of this job already. On the top of the slide, you can see that we emphasize the assistance for the projects, educational activity, research activity, and implementation of the Universal Declaration on Bioethics and Human Rights. If you look through the Universal Declaration on Bioethics and Human Rights, all these aspects are included into the term of bioethics, and you will see it. And Dmitry Olegovich will tell us today about these aspects, and that they are not the only ones which are included into the meaning of bioethics. It is a huge area. In this regard, we conducted an international conference in Minsk from the 1st to the 3rd of December, and during the conference, with the help of the stakeholders who are professional communities and international organizations, we established an international institution on bioethics. For these 2 years, we have done a huge work with the UNESCO Intergovernmental Commission on Bioethics and with governments of some countries. So what do we have today? While we were conducting the analysis, we realized that almost in all countries there are the legislative documents on bioethics that are connected only with the system of healthcare. In some countries, there are several representatives of other governmental institutions who participate in these state committees, though bioethics is a much bigger area, as I mentioned earlier. We conducted consultations during 2 years. Then, within the International Institution on Bioethics, we started forming and writing down the conception of the work of the structured system on bioethics in our region. We got support, first of all, from the parliaments to create the coordinating councils on bioethics under the parliaments of the CIS member nations. We established the commissions on the principles of bioethics and evidence-based medicine under the expert councils on healthcare under the Interparliamentary Assembly. We are working on creating the main principles of the commissions on bioethics and human rights under the Interparliamentary Assembly and CIS Expert Committee. And in February in Kazan, we will have an off-site meeting of the UNESCO where they will discuss the offer of our experts to create the Commission on Bioethics and Human Rights for the CIS member nations at UNESCO. And pay your attention that this time it will be the Commission under the UNESCO, not under the Interparliamentary Assembly. And we have a preliminary confirmation already. Moreover, we have established 2 coordinating centers. One of them is in Minsk, and it is an Eastern European center. Another one is in Tashkent, and it is the coordinating center in Central Asia. The platforms that support us are Oslo in Norway, Paris, Philadelphia, Washington DC, and Helsinki. After my speech, I would like to communicate to the specialists who participate in the Congress today, because Alexander Vladimirovich and I discussed the possibility to collaborate on rehabilitation issues last year. Unfortunately, the pandemics hindered our plans. And one more time, I would like to lay stress on our region that is official from the UN's point of view, and it happened on the 23rd of November last year. We have discussed 2 directions that are human health and well-being and education. That coincides with the 3rd and the 4th SDGs. Thank you for your attention. Thank you a lot, Sergey Ivanovich. We will have a lot of online connections now, and we have to follow strictly the schedule. It is a highly important topic that has been just raised. The next speech is by Dr. Satish Mishra from the WHO European Bureau, and it is called the Sustainable Development Goals, Rehabilitation 2030 and the WHO European Experience. You are welcome.
Good morning and good afternoon, everybody. First of all, I'd like to welcome all the delegates and participants for the 4th National Congress. And I'll be speaking on Rehabilitation 2030 with an emphasis on the global and national experiences. To do that, I'll do a presentation. Good. I think it's visible now. I'm Satish Mishra. I'm the regional advisor on disability and rehabilitation for the WHO Regional Office for Europe, which is one of the 6 regional offices for WHO. In today's presentation, I'll give an overview of rehabilitation in the context of Sustainable Development Goal. And I'll also speak and present about Rehabilitation 2030 and WHO European Regional Office role in the same. Before I go further, WHO Regional Office for Europe is one of the 6 regional offices for World Health Organization. It's based in Denmark. The WHO European Regional Office covers 53 countries, 53 member states, with over 900 million people in the region. The regional office is based in Copenhagen, and we have country offices in 30 member states in the region. In the WHO European region, the prevalence of non-communicable diseases such as cardiovascular disease, diabetes, chronic respiratory conditions, cancers is rising. Compounded by population aging and improved access to emergency trauma and medical care, there's a growing demand for rehabilitation services. For these regions, WHO European Regional Office created in 2019 a disability and rehabilitation program. The program supports countries in implementing rehabilitation services into their health system. The WHO European Regional Disability and Rehabilitation Program has 4 areas of work. Number 1, in improving access to quality health services for people with disabilities. Number 2, strengthening rehabilitation services, including access to assistive products. Number 3, strengthening relevant and international comparable data on disability. And we also cover areas related with eye care as well as ear and hearing care, and to secure access to those who need those services. I'll be speaking a little more detail about rehabilitation and its linkages with Sustainable Development Goal. Universal health coverage means that all people have access to health services they need, when they need, and where they need, without financial hardship. It includes the full range of essential health services, ranging from health promotion, prevention, to treatment, to rehabilitation and palliative care. Achieving universal health coverage is one of the targets set by 2030 Sustainable Development Goals. Rehabilitation is an essential health services and recognized as such in the definition of universal health coverage. Thus, universal health coverage cannot be achieved without provision of rehabilitation services. Rehabilitation is an important part of universal health coverage and is a key strategy for achieving Sustainable Development Goal, especially goal number 3, which is dedicated on health services. But also on others, rehabilitation services also contributes on other Sustainable Development Goals, like Sustainable Development Goal number 4, which is focused on ensuring quality education, or Sustainable Development Goal number 8, which focuses on decent work and economical growth. The positive health, social, and economic effects of rehabilitation can have a profound impact on population health, cementing rehabilitation position as an essential health service. In WHO European region, evidence indicates that there are 394 million people with a disease or impairment who needs rehabilitation during the course of the illness or the disease. This represents 2 in 5 inhabitants. Musculoskeletal disorders, sensory impairments, neurological disorders are the most prevalent group of disease and injuries. All estimates are from 2019, before the COVID-19 pandemic. Many countries have very limited rehabilitation services, and many people do not receive the rehabilitation they need. Rehabilitation has often seen as a disability-specific services only needed by few of the population. But in reality, rehabilitation services are needed by many health conditions and can benefit anyone regardless of their age, gender, or socioeconomic status. Despite its individual and societal benefits, rehabilitation has not been prioritized in countries and is often under-resourced. Rehabilitation addresses the impact of a health condition on a person's life with a primary focus on improving and maintaining their function. Difficulties in functioning occur because of impairments in the body functions like pain or muscle weakness, which results in limitation in functioning, example in walking or self-care or mobility or vision or hearing, and restricts the participation in community, in life, in work. World Health Organization defines rehabilitation as a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction of their environment. Rehabilitation addresses a person's limitations in everyday physical, mental, and social functioning due to aging or a health condition, including chronic disease or disorders, injuries, or trauma. Fundamentally, rehabilitation focuses on functioning of an individual and not on the disease. It does this through a strong emphasis on optimizing functioning, education, and empowering people to manage their health condition, adjust to their situations, and remain active. Evidence shows that rehabilitation interventions are cost-effective and help to achieve and maintain the best outcomes of other health interventions. Rehabilitation has the potential to avoid costly hospitalization and reduce hospital length of stay, decrease readmissions, and reduce the risk of complications due to health problems by improving function and ability to participate in everyday life. Rehabilitation cuts the cost of ongoing care and support in individuals to participate in education and employment. Evidence has shown that functional capability can be improved even with low-cost interventions in low-resource settings. Rehabilitation workers include people belonging to the profession of occupational therapist or ergotherapist, physiotherapist, prosthetist, orthotist, psychologist, doctors, nurses, social workers, or speech and language therapist. Depending on person's need, rehabilitation may be provided by one profession, or although it often requires a multi-professional collaboration. What are the factors which are driving the increase in need of rehabilitation? Aging is one of the major factors which is driving the increase for need for rehabilitation services. Increasing age correlates with multimorbidity and functional impairments resulting from frailty, impaired condition, as well as continence, gait, or balance problems. Collectively, these functional deficits lead to higher risk of disability and difficulties in completing essential daily activities. The other factors which are driving the need for rehabilitation is non-communicable disease. Non-communicable disease can lead to impairments related to amputations, visions, mobility, or speech problems. Such functioning limitation can challenge participation in employment, societal activities, leading to isolation and poverty, and increased demand on the health and the social system. The other category of population which are driving the need for rehabilitation is people with disabilities. Rehabilitation for people with disability aims at enabling person to reach and maintain their optimal physical, sensory, intellectual, psychological, and social functioning level. Rehabilitation and assistive products enable person with disability to attain as much independence and self-determination as possible. Access to rehabilitation is also a human right, which is enshrined in the Convention on Rights of People with Disabilities. The other factor which is driving the increase in need of rehabilitation in the WHO European region is violence and unintentional injuries, which are leading to death, human suffering, and disability. Injuries resulting from road traffic, accidents, falls, poisoning, acts of violence against oneself or others are some of the other causes which are leading an increase of need for rehabilitation services. If you look at COVID-19, rehabilitation has been recognized as an essential component of medical response in health emergencies and disease outbreak by World Health Organizations. In spite of that, services has been closed during the pandemic as they were thought to be non-essential or due to lack of staff from illness or redeployment to other clinical services. These service disruptions have posed significant challenges to those who rely on rehabilitation services for long-term management of chronic conditions. The world has tracked the development of COVID-19 pandemic mostly in terms of numbers of identified cases and deaths. Yet these measures provide only a partial picture of the COVID-19 impact. Many people struggle to recover fully from COVID-19 infection, whether hospitalized or not, suffering disabling symptoms and functional deficits such as breathlessness, fatigue, and deconditioning for weeks, months, or longer that are amenable to rehabilitation. Our understanding of post-COVID-19 condition, or often termed as long COVID by patient groups, is still evolving, but the condition can be very debilitating. If you look at some of the data from the WHO European region on the impact of COVID-19 and rehabilitation, 1 in 6 need ongoing rehabilitation after leaving hospital. In UK, in May 2021, there are more than 1 million people who self-reported as having post-COVID-19 condition or long COVID. What are the major challenges in accessing rehabilitation services? Lack of human resource, lack of rehabilitation services in rural areas, and at all levels of healthcare. Absence of policies and programs, limited data, limited funding, lack of integration into health system, and a general lack of information about the benefit and potential of rehabilitation services. And this is one of the reasons why some of the countries report that more than 50% of people who require rehabilitation services do not receive them. The demand for rehabilitation services already exceeds availability, leaving a large unmet need. To address the lack of rehabilitation services, World Health Organization has come up with different tools and guidance. And as we continue to respond to COVID-19 and plan for healthy recovery from COVID-19, there's a need to establish a system that guarantee more inclusive and resilient economies and communities that enable everyone to participate. Access to rehabilitation and assistive technology is vital to this. Rehabilitation professionals and services are key for better health, leaving no one behind and achieving equitable society in the WHO European region. World Health Organization is committed to support countries in the European region in integrating member rehabilitation into their health system, as we recognize the importance of rehabilitation services for better health and achieving equitable society in the WHO European region. In 2017, World Health Organization launched an initiative called Rehabilitation 2030, a call for action. It appeals to countries to strengthen their health system to provide rehabilitation services. Rehabilitation in health system, a guide for action as a guidance document and toolkit was also launched, which has a primary objective to provide practical guidance for governments on how to strengthen the different building blocks of the health system for rehabilitation. In many countries, rehabilitation workforce is under-equipped to meet population need due to large-scale shortage across professions and specializations and issues of quality and relevance. As the demand of rehabilitation escalates, the need to expand workforce protection and strengthen regulation and quality assurance mechanism becomes increasingly critical, especially in low resource settings. Rehabilitation competency framework defines the core values and beliefs shared by the rehabilitation workforce, encompasses the competencies, behavior, knowledge, and skills required to perform a range of activities and tasks involved in rehabilitation service delivery. There are 2 other resources which are in progress and are expected to be completed by end of 2021 and launched early 2022. One resource is package of intervention for rehabilitation, which will support countries in making decisions around service planning and budgeting for rehabilitation according to country needs and priorities. It's part of it. It will also be part of the Universal Health Coverage Compendium. One more important resource, which is going to be also launched by next year, is a basic rehabilitation package for primary healthcare in targeting specifically low resource settings. It's a package of low cost, high impact rehabilitation interventions that can be safely and effectively delivered by primary healthcare workers. As we know, these are more often than not the main point of contact in low and middle income countries. What needs to be done? We need to strengthen rehabilitation planning and implementation in the countries. We need to build comprehensive rehabilitation service delivery models, including those for assistive products in the countries. We need to develop a strong multidisciplinary rehabilitation workforce, promoting rehabilitation concept across health workforce education programs. We need to integrate rehabilitation in healthcare, not as an afterthought, but as a part of prevention and long-term strategy. I'd like to end my presentation by giving four key messages. Number one, public health strategies aren't going to be inclusive if they don't include people with disabilities, which means rehabilitation services need to be also included in public health strategies. The need for rehabilitation is growing. Universal health coverage and sustainable development goals cannot be achieved without rehabilitation. Rehabilitation is an investment with far-reaching economical and societal benefits, and therefore needs to be prioritized. In conclusion, rehabilitation is a global health issue, and we need strong data, evidence, policy, and investment across health system to meet the growing need for rehabilitation services. Thank you very much for your time, and thank you very much for the opportunity for World Health Organization to speak today. We'd like to thank you for inviting us for the 4th National Congress. And I wish all the participants of the Congress a very successful Congress. Thank you very much.
Thank you, Satish. Next speech is the reflection of Sustainable Development Goals in Statistical Indicators on Disability in the Russian Federation. It will be done by Kristina Rozhko. Good afternoon, dear colleagues, and thank you for this possibility to speak today about the reflection of the Sustainable Development Goals in the statistical indicators in the country. And I would like to continue the idea that Satish has just mentioned, and to speak about the global international documents that can be implemented in the country and can be used in monitoring the quality of the system of comprehensive rehabilitation and habilitation of the people with disabilities. To start with, let me remind you what the Sustainable Development Goals, or SDGs, are. They were adopted by the General Assembly of the United Nations in 2015 in the resolution that was called Transforming Our World, the 2030 Agenda for Sustainable Development. And they substituted 17 goals, substituted 8 Millennium Development Goals. When the resolution appeared, the UN specialized agencies started their work on elaborating the conceptions how to achieve the goals. There are 17 SDGs that contain 169 targets and 232 global indicators of achievement of SDGs were developed later by the UN. Speaking about the work of the WHO on the SDGs issues, we can say that they developed the package of documentation that Satish has already mentioned. Currently, it contains 3 documents. The first one is called Rehabilitation 2030, a call for action. It is a small document, a small conceptual note that shows the main directions of the rehabilitation development.
The second document appeared last year. It is Rehabilitation in Healthcare System document. It's a guidance for action. So it specifies how to structure and improve the system. And the third document is about competence model. It contains the list of skills and knowledge different specialists should have if they are involved in complex rehabilitation area on all levels, both management level and I would like to get more specific about call for action document. This is the document which shows the need to divide the process of restructurization in 4 phases. The first is evaluation phase, which helps supervisory bodies. This complex evaluation is important to create a high-quality report. The evaluation can be done both in the region and on the national level. Today, we already spoke about the CIS actions, and it's here the same system. The second phase implies plan creation, which of course will be based on evaluation document. The third phase implies monitoring and the startup processes. And the fourth phase is the very implementation in practice. It is supposed that the first 3 phases will be performed within 1 year, and the fourth one will take about 4 years. And here it's important to say that there is difference between strategic and operational planning processes. For example, during the second phase, we're talking about strategic planning, while operational planning shall happen every year during the fourth phase. As I already mentioned, the document is very detailed. The phases are subdivided into sub-stages and they into smaller actions. Here we can see the tools list. Every stage implies specific tools usage, depending on the results we are going to achieve at the end of every sub-stage. You can see on the screen all 4 phases described. The first is analysis of the current situation and the evaluation of it, preparing for the analysis, collecting data, evaluating the situation in the country, and writing the report of best quality possible. And then, of course, we have to explain the results of this report to all participating executive power bodies. The next stage is strategic planning. We should identify priorities of the very project plan. Then we have to discuss priorities and future plan with all interested participants. And then we finalize the plan, explain it, and distribute to everyone involved. The third phase is connected with monitoring. It is about developing basics of monitoring and optimizing check process. The fourth phase is the very implementation. Here we also run monitoring, but it's already practical monitoring. Today, I would like to focus more on how we can be more effective during the third phase and how we can run monitoring efficiently. As I already mentioned, there are in total 17 sustainability goals, and they, to different extent, cover the disabled people, but we took only priority ones. First, we filtered to 11 goals. Then out of 169 tasks, we identified 24 tasks. And so such subdivision, decomposition of these tasks and goals allowed us to set priorities. Then we correlated them with the country needs and complex rehabilitation purposes. We used UN document, which is called Report on Incapacity. It specifies how all sustainability goals can be reflected when in our work with the disabled people. We also analyzed this report more thoroughly, and on the basis of our experience, when dealing with regional projects, we outlined key vectors of development. In the middle of this scheme, you see 4 key tools to be used in all other 4 areas. These areas are enumerated in the side part of this diagram. You see that all the elements are connected with each other by means of IT tools. We also have to apply legislation tools. This is extremely important part of any process, and it should be taken into account when reconsidering rehabilitation programs. Then we should think about technical means. And the last part, the last but not least, is on how we react in case of emergencies. Last year showed us how important it is to provide proper reaction. And this has always been a very important strategic issue, but the practice showed that there is no acme of perfection. We should go on developing. Here you can see that we added to this scheme particular sustainability goals, and we can say that information and means of media are here the key ones. Now I would like to say what Russia has already done for these sustainability goals purposes. Back to 7th of May 2018, our president issued a decree on national goals and strategic tasks of Russian Federation development for the period up to 2024. This was the period for which sustainability goals were to be integrated. Also, there were 12 national projects developed and a complex plan of modernization and infrastructure expansion was proposed. You can find all this information on official websites. As for the 3rd phase of development and implementation of our new strategic plan is monitoring. Russian statistics body is responsible for monitoring, and this organization listed key indicators and indexes for this purpose. They analyzed how to integrate formulated indicators formulated by UN into our Russian program. We also got national review of how the agenda of sustainable development was being implemented. And as I already mentioned, most of monitoring is performed by Russian Statistics Institution and Ministry of Foreign Affairs. Here you can see global indexes related to sustainability goals. In comparison with national indicators. From the left part of this table, you can see the tasks enumerated. The middle column is formulation of the global indicator proposed by UN, and the right column shows the correlation, the coefficients used, and possibilities of integration in the country. On the whole, we have 23 indicators in our national set, which are related to rehabilitation, but unfortunately only 4 of them are directly connected with the disabled people. 16 indicators out of 32 selected are not reflected in our national list. There was the selection made by a Russian statistics institution. You can see comparative analysis with other Russian statistics organization sources. We analyze such sources as state program, which is called Available Environment, and also some programs developed by Russian Statistics Department every year. Again, the same type of table is displayed here. The task SDG task from the left part, from the left column, and the indicator, and finally the right column is the correlation and what we can really use. In the end, we got 18 indicators out of 32. SDG 3 and 4, healthcare and education, and also SDG 8, which is work and economics growth, were covered in the first place most deeply. When talking about monitoring and controlling complex rehabilitation system, we should of course mention WHO classification family. There are 3 classification types developed by WHO since last century. 2 of them are used successfully. International diseases classification and international classification of functioning, which also takes into account limitations of those who have some disabilities. There is also the 3rd classification here. It is dedicated to medical and social interventions. The English name is ICHI. All these can be used as tools for evaluating situation, and they can show the results, so that in the end we see at what level our country is now and compare these results with sustainability goals. In conclusion, I would like to mention that UN documents specify with a lot of details all the basic statements for monitoring, and it's really a good guidance to use. In the country, we have quite a good basis for future development. Now we work with regional programs projects. And we are sure that our regions are ready for annual monitoring, which will be on the regular basis. The regions understand what complex approach means, and they are ready to develop. They receive all the necessary information and try to present their results every year. ICF is really a very good tool. Don't forget about it. And here you can see our offers on how we can implement everything. First, we can create coordination council to achieve SDGs. We can also develop and approve unified system of SDG indicators. We see that even within one document, there can be some confusions in terms of documentation and terminology. So we need some unified system. It should be one single format, one single terminology and indicators, because we want all the participants to have the same vision and understanding of it. Another proposal is to determine responsibilities. We should appoint those who are responsible for monitoring. Educational, healthcare institutions, employment institutions should understand the influence and importance of our topic. And of course, we should distribute correct responsibilities for SDG implementation in practice. That's all from my side. Thank you very much for your attention. Thank you very much, Kristina.
Now it's turn for Alexander Shoshmin to present his speech that is called International Classification of Functioning Disability and Health and Other Tools to Organize Rehabilitation.
Good afternoon, dear colleagues. I'm very sorry that we are running out of time and that we are lagging behind our agenda. But every speech is unique and it was very difficult to cut you short. We are living in the digital era, and the international classification of diseases was adopted several years ago, and right now there are different regulatory decrees and acts that we have to put into practice, and in practice everything is more challenging. So I also work with the WHO and with the center responsible for training in ICF. So ICF is a classification. It is just a classification. It's not a tool, and it should be used as it is. ICF is an ideology. It is a philosophy, and from this point of view, we will try to take a glimpse of this classification and see how it can be used as a view, as a vision of the patient and their rehabilitation. We will see rehabilitation as one of the cases where we can use this classification, because rehabilitation is focused on functioning and not on a disease. When in medical documents and in regulatory documents we see such concepts as rehabilitation diagnosis, I do not like this in particular, because ICF was proposed as something opposite to diagnosis. Diagnosis is something static, while ICF is about something, how we need to work with the patient after the patient was diagnosed, no matter what the treatment outcome is. So that is why I can see a sort of contradiction here. So why, from the point of view of diagnosis, we can't consider the person from the point of view of diagnosis when we do rehabilitation? If we take people with Down syndrome, we look at ICF and we can see how 4 patients aged 9 to 12 change their functioning. We can see that every one of the children has their own specific characteristic functioning pattern, and every one of them requires a different approach while the diagnosis is the same. And in this case, replication would be the same, while ICF requires an individual approach. So we need to see in particular how to adjust a particular curriculum, a particular rehabilitation program rather, to every single child, although their diagnosis is the same. So why did this happen? Uh, there was an interesting survey performed, and part of people believe that Down syndrome is genetic, and half of them identify other reasons like bad fate or bad luck and so on and so forth. So it means that half of people do not understand what is the real cause of this disease. The majority wants to feel better on the one side, but on the other side, of course, they want to get the benefits that they are authorized to get when they are disabled. So many people see a child as a source of subsistence. So in this case, what kind of rehabilitation can be provided? We need to approach rehabilitation per se in a very careful manner and not use a medical model that means that a doctor will handle it and disability will go away. No, this doesn't happen like that. Disability doesn't go away as easily. So there is a social model, a social approach when we see whether the person will benefit from it or not. There is also a legal model. We can constantly advocate the rights of the disabled, but it's still not enough. So the philosophy that is offered as part of ICF is to take an integrative biopsychosocial model of functioning and disability as a basis, use it as a basis to change the vision of people with disabilities. So disability means complex functioning at the level of the organism, individual, or a society in one or different fields of life. When a person meets a specific disease and a specific condition and specific environment. So we can say that ICF is not just some sort of indicator that shows that a person is disabled or not. It is a tool that helps us to cover the entire and describe the entire scope of disabilities from complete disability to partial disability. And from the point of view of the government and disability benefits, this is a different topic. And it is up to them to decide when to provide these disability benefits or not, and to set the threshold. So the problems in different countries are the same, and the population is more or less the same. And in some countries, there still can be differences. So we understand that ICF includes contextual factors and functioning and disabilities. Functioning and disabilities include functions and structures of the organism, activity and involvement. As any classification, it is subgraded endlessly. And there are rules to be followed when a code is written, and there is a letter that indicates the domain to which a code belongs. There is a digital code that shows the titulization, the specific category of a specific factor, and there are determinants. This is something unique because unlike the diagnosis that establishes the presence of a disability, this determinant shows how expressed this or that disability is, using a score from 0 to 5, 0 meaning that there are lacking signs, 1 meaning that there are some subtle signs, and so on and so forth. So the functions and structures of the organism have very large similarities to ICD-10. But in this case, why should we reinvent the wheel if it is already available? Well, actually, functions and structures can be evaluated independently. If there are visual impairments, it doesn't mean that the person doesn't have eyes. There can be disorders in metabolism or the cortex and so on and so forth. So different structures can be damaged differently. This correlation between structures and functions cannot be drawn. This is not right. This is not correct. So what do we usually focus on during rehabilitation? We want it or we don't want it. We want, of course, not to perform a heart transplant, but we want to improve person's cardiovascular activities. So we do not want radical measures, and that is why we focus on such categories as activity and participation. There are also environmental factors that can be factored in. This involves changes in the environment, man-made changes, and support and links, personal relations. The different presumptions in the society that we try to overcome. We want people uh, to accept the rights of other people, even they have special needs to join their peers, regular peers. So there is also another level that has to be taken into account, like services, administrative systems, and policies. I know an example when one of the colleagues in the WHO went out to evaluate the consequences of a typhoon in the Aegean, in the Indian Ocean, and using ICF, she described what has to be done so as to rehabilitate, restore the structure of a specific island there. So the opportunities of this classification are enormous. From the point of view of rehabilitation, we have a classical cycle of rehabilitation, including the initial evaluation, goal setting, intervention, and result evaluation. Let's go quickly through these stages to see how we can work with this classification. There is a typical situation when you want some coffee in the morning, but you feel lazy and you don't want to get out of bed. So let's break this down from the point of view of ICF. It's just something as a joke, a funny example. So what can we identify as a linking unit? I cannot go to work and earn money without coffee, without a cup of coffee. So what is coffee? Coffee is E11,000, meaning foodstuffs. Um, Getting up from bed, it means changing the body position. Going to an office by car is related to transport control. So any text can be translated into the language of ICF and can be coded. Actually, you can cipher any message using ICF. Like, for example, the phrase talking by the phone can be coded as a conversation according to ICF. So how do we perform evaluation? Of course, you do not use all of the 1,700 categories in ICF, but you use only those that you might need, because when some say that there are too many, they are true, but it doesn't mean that they need to use them. You need to use only those that have a positive resource, something you can affect. What those that can have a negative impact? Only those categories should be taken into account that can be modified. Otherwise, why spend any efforts on them? And you use only those categories that affect the goals of one or several rehabilitation cycles. Of course, you need to use references, reference books, and there is a basic, there are basic sets, ICF sets of categories that you use so as to single out from all these 1,700 categories of ICF, just 60 to 70, like cerebral palsy and so on and so forth. So there are specific cases. For example, there is a basic set on rehabilitation or professional rehabilitation. Uh, they are linked, these core sets are linked to only the unit that you're being observed, that you're being observing, that you're observing. So in the entire globe, you test core sets. There are observations done across the globe. Specialists in different fields perform patient surveys, and administrators get involved, managers that work with patients, researchers also make a contribution. Then literature review is performed, and they see which core sets are most relevant. And after that, they see which sets actually work, and only after that is a core set of ICF actually approved. So they're not just taken out of nowhere. Otherwise, they cannot be practically used. So now let's talk about the functions of the organisms.
эти справочники, когда
We
базовые
have to use this reference to select categories which are most relevant in this particular case. We should be aware of what we really need in practice. And of course, we can check this reference books, manuals, and see what functionalities are the key ones. Some of them are more difficult to be recovered. Our ex-general director, sorry, I forgot his name, Igor, he showed fantastic results transplanting the fingers in case they lose the thumb. He could not only transplant the fingers, but to recover the functionality so that they can grasp things with the fingers. And of course, this is the target function, which is difficult to be dealt with, but it's possible. So the basis of every rehabilitation program is to understand what environment the patient lives in. Can he uses the facilities we propose? For example, if we propose a wheelchair, we should be sure that the person can use it in his block of house, that his elevator, for example, is spacious enough, and that he can go out the house and get back. Once we had a case when a girl got a surgery for her spine, and rehabilitation was obstacularized by the environment. So at that particular moment, we realized that we should take this environment in every particular case. So it should be a personalized approach, not just a general one. We should always monitor what is going on in the patient's life and correct our activities on the basis of these observations. ICF is always an evaluation for here and now. It is not the evaluation of the past or the evaluation of the future. We don't know what's going to happen tomorrow, but we know that at this particular moment, we have this particular state and we have to do something with it to achieve the goals. On the basis of all this, we can show you the following protocol for the primary check. We get the information necessary for rehabilitation program development here in this check. And after we already select the necessary data and determine the category for the patient, we get the list. I will show you an example. This is a categorical profile, a very helpful tool. We just draw here what degree of malfunction each category has. How about setting goals? One of the key mistakes here is the attempts to outline specific goals of medical rehabilitation. For example, we cannot say that the target of rehabilitation is heart transplantation. We have an object, and our task is to improve the person's life in the first place and not just to transplant something. This is where we have to say that every patient has some barriers or limitations, and we should identify those actions which can help us to overcome these barriers. Looking more attentively at one of the WHO posts, we can see that in the first place, patients have to look at their mobility capacity, how they can take care of themselves, how functional they are when dealing with routine life. And we usually assign some category at such a level when it cannot be already changed. So in case those who are responsible for rehabilitation, they already should take the process from those who have been responsible for treatment. So these are two different parts. And when we already assign some category, that already specifies to which level the patient can improve. When we look at the things from this angle, we get better results. So between rehabilitation logic and patient, there should be very clear link. Next point. Each category implies certain interventions. If we want to improve blood circulation, we can apply some massage therapy, morning gymnastics, or positive emotions. Certain number of procedures can influence this category of people. But there is such a classification mentioned by Kristina that which is an international classification of medical interventions. But of course, it's not only about medical, but also about social interventions. So as a target of any intervention, we can see their ICF. When opening this classification, we see that ICF is the basis for any other intervention. So the target can be the function or some participation or some structure or environmental factors. No other intervention can be thought of here. What we can do is that we can apply any number of interventions to each category. So in case we formalize it, it will be different. But we see that now we don't have the real structure. There is something assigned to social interventions, something assigned to medical intervention, but there is no separate rehabilitation intervention. So we need the very structure that would be able to cover almost, to cover all the aspects: social protection, education, healthcare, everything. So if we speak about sports, then what kind of components shall be included? This is what we should answer. And again, personalized approach. We know that every specialist is responsible for several categories assigned to him, but we need a joint team. There are so many categories which at the same time refer to different specialists. So only joint work can allow us identify the core action to be done. Then we should make a very simple step. We can never influence everything at once. We should first understand what our priority is, what will be our first target, and what will be our next target, and what the patient agrees to. Because we probably should speak about needs. Sometimes the person is interested in opening the bag, or the target can be different. So depending on the particular needs of this particular person, we should correlate these needs with our priorities. Because if his or her targets don't coincide with ours, whatever we do, we cannot achieve good results. This is a co-creation between the specialist and the patient. Taking rehabilitation of long-term patients, we all the time work with them, and we cannot just focus on one institution. The process implies various institutions. Each of institution is responsible for a particular area. And when we see these different processes happening in the parallel, we need to make them aligned with one another. There are different options now available, and we can monitor people's health now from ICF point of view. In Russia as a whole. Now, taking early intervention, we can say that it is already applied and practiced, and I hope that soon we will implement it for children rehabilitation. As for adults, it may be a little bit more complicated because here we have to take into account a lot of different areas. But for each particular case, there should be assigned a special supervisor who will be accompanying such people within long-term perspective. Such positions already exist in highly developed countries. They have different names in each country, but more or less the function is the same. They manage the particular case, the particular person in long-term perspective. Now, about intervention. Of course, all intervention procedures should be justified. For example, let's take a child with a palsy, and in case there are some cases when parents with such children get to see us, and then they see that there is no massage on the list. She just leave unsatisfied. But we should first of all look at the indications whether this particular procedure should be really assigned to this person, whether it will bring us to the necessary result. Only in this case we can use the same ICF mechanism and understand better at every particular stage what is going on with the patient. And when changing category, it's important to change program. It should not necessarily be fixed. It is not some state standard. It is some flexible approach allowing us to influence most efficiently on the patients. And now we should talk about result evaluation. It seems very complicated at first sight, but in fact, it's much easier than it seems. If at first we set properly targets, we can at once say what is the degree of malfunction expression. And here we can either improve the situation or to keep the balance without letting it getting worse. And when evaluating results, we can check whether we have achieved this goal or not. Depending on disease, we should understand the timeline. Something can be achieved within 3 months, within 3 weeks if it is Down syndrome, but in case of autism, it can take much longer time. So we should even year. So every tool implies its own time period. And we shouldn't just take the same time period evaluating the result. We can say that, for example, at this particular moment, we don't have result. That means that the tool is not effective. It's not the correct approach. Comparing what was before and what is now, we can say whether we have changes or not. The system works very well for the very patients. Unfortunately, Mr. Bronikov didn't have a chance to come here, but in his center, he has patients checked before the program and after the program. The patients are informed what are the key focuses of the program, and in 2 or 3 weeks, they can see the results, physically measured results. This is what we're talking about. We can say that, for example, instead of 2 steps, now you can make 5 steps, or now it is possible for you to touch your nose. So this is a very effective tool for the patient to see what are the exact changes that have happened to him recently. It's very rarely that rehabilitation just stops for good, explaining that, oh, now everything is already completed. No, it is some constantly evolving process. We are very open. We are ready to train. So in case you want to receive any training program from us, we are always ready to help. So we are helping Russia, CS countries. And in case you have everyone who speaks Russian. So in case you have any questions now, please feel free to ask. I hope I covered all important issues. Do you have any questions right now? Okay, no questions. Then thank you very much for your attention.
Dear colleagues, we are ready to continue our session, and now it's turn for Dr. Sergey Cherkasov to present his speech with the topic "The role of the family of international classifications in public health management and the achievement of Sustainable Development Goals." Good afternoon, dear colleagues, and I'm happy to be here with you today.
Many colleagues and I also spoke about the role of separate elements of this group, of this family. ICD, ICF, and so on. And there is a new classification of interventions that is also making headway. So why do we show so much interest to this classification? If we try to create a structural scheme showing the role of this family of classification as a basis for public health management, we need to understand that if we want to manage a process, we need to know the starting point. We need to plan and forecast the end point and plan the activities, results, and needs that we will need to follow this pathway from the starting point to the end point. So if we translate this into practice, we can see that in this process, we should use management technologies such as identifying the volume of needs, the scope of needs, identifying the resources, planning resources, and based on planning and the objectives that we have posited and the processes that we are observing, we need to take them into account to forecast the future state. So right now, human health is seen as cross-disciplinary interaction area. It is only in this case that we can speak about real public health and not public health from one narrow perspective, like medical perspective, mobility, and so on, and disability. But we can exercise a broad approach to this as a tool that allows the state to reach the goals, and in particular, sustainable development goals. A lot has been already said, but I want to again flag that the quality of data that we have can be doubted, put into question. If we take a look at international research review, there was a serious study in cardiology, and we can state that clinicians and researchers need to be aware of the limitations of even the key primary basic data that are used in decision making. We need to make decisions based on data that are available. And actually, it happens that those data that we have are dubious. In this case, the situation is bad. How can we control this data and how can we attain our goals if we can't, if we don't have anything to rely upon? So as an example, I would like to show you the mortality rather coefficient related to chronic coronary heart disease, I-25.2, quite popular in Russia. But you can see the difference between the United States and Russia from the point of view of this coefficient, of this factor. So does it mean that everything is so bad in Russia because we can't use technologies that are applied in the USA, or is the reason related to something else? We have a clear understanding that the coding technology is violated, and this figure is not correct. It is not appropriate. We cannot rely on it. In this case, the question is, which figure do we use to rely on? So does it mean that in the United States they are performing everything correctly, so that this figure is correct? If we take, there is no answer to this question. If we take a look at cardiology, why do we take a cardiology as an example? Heart diseases are the primary cause of disease in the Russian Federation. So if we take a look at the United States, we can see that there is infarction, acute infarction of identified location, and we are trying to split infarctions into different types depending on their site, depending on their location. Probably there is a point about that. But in the United States, they do not perform this subclassification of acute infarction. And myocardial infarction um, actually causes much more deaths here in Russia. So why is that? Because the rehabilitation is bad, or probably there are some problems related to statistics and the data are not reliable. And we cannot use this data to reflect the real scope of the problem. So this is the first point. The data that we have are doubted, they're dubious. So there are different institutes. One of them is um, the Institute for Control of Different Aspects, including social and economic aspects. And at our institute, when we develop some programs and research designs, then usually they object to us by saying that we do not have enough of physical data. If we take a look at mortality, uh, mortality is something that entails accumulation of new data all the time. And we can say that only 15% of the real volume of data contained regarding this matter makes part of statistics, and we do not have access to primary raw data, input data. And even if we take a look at our realities, statistical records, statistics are only based on death certificates and a limited number of records. So when ICD 11 is introduced, in this case, the total volume of information will be reduced to 2.3 to 2 from 2 to 3% if we keep the same methods and approaches to registration of data, to recording of data. So how do we bring this quality of data higher? How do we bring them up? So in our institute, it was identified that some of the regions actually accumulate quite a lot of information, which is not part of official statistics. And we analyzed this data from the mathematical point of view. And actually, we came up with a chaotic representation. This has to do with the fact that everyone uses their own rules. So although we have unified rules and documents, everyone who fills in a document, who fills in a record, does it using their own considerations, their own reasons. And that's how we end up in this chaos. So how can and how do we need to use this family of international classifications? Without using them, we will not end up with a body of evidence or provide expert support for decision making in public health care. And moreover, it is impossible to ensure rational, reasonable planning and distribute healthcare resources without the use of these classifications and without the use of respective data. We won't be able to plan the required amount of resources. And another point that was actually articulated by all the speakers and Alexander Vladimirovich in particular, it is that we split we split international classifications across different departments and ministries. So what is ICD about? It is about a disease, whether a person has a specific disease or not. And another ministry will be responsible for ICF. Of course, this ICF classification is needed, but it is also needed by the Ministry of Health. And for example, I do not even know which ministry will be in charge of the third classification, the International Classification of Health Interventions. That is why I would say that this family of classifications falls within the scope of responsibility of some supranational institutions. Attaining, or rather, uh, there should be a single legislative framework that should be used. For example, uh, some of the decrees do not affect some organizations and they affect the others. As a result, we see a bad case of fragmentation. And as Sergey Ivanovich mentioned, when in today's conditions we in today's conditions, we need some agreement at the level of supranational use of these classifications using harmonized descriptions. Otherwise, we will come up with very narrow structures, which will be impossible to be analyzed. It doesn't mean that all the countries should shift to some common single technology. It is quite impossible and not needed. But anyway, we need to understand how to compare these data, at least in the list. On the other hand, this global area cannot be propelled without the participation of rich countries, wealthy countries. And in terms of countries with more limited resources, it would be better to pool their resources. In this case, we would come up with a shared tool to be used, and on the other hand, we would spare the limited resources we have. Bringing back to the previous slide, I would like to once again to say that without derivative classifications, we cannot do anything. And actually, this idea was promoted for several years. The idea is that the a term related to the cause of death as formulated in the death certificate should be taken from the third volume. We understand that this can be helpful, but on the other hand, we can see that we don't have a tool to be used. So there should be a tool that would help a doctor not to try to struggle through these wordings and find anything suitable, but they should be provided with a full-fledged derivative classification that they can use so as to find the wording that will suit their needs. And so far, there is no system in this matter. So it means that the decision has been taken, but it is not clear how to implement it. If we take a look at a more complicated classification, the ICHI, we can see there a structure, a dimensional structure, multidimensional structure that brings together ICD and ICF, and it will help us move in the direction we are striving for. It is supposed to help us ensure the required effects and to get closer to sustainable development goals that we have planned to achieve. Probably we need to somehow adjust to our trajectory, and it is only this family of classifications that will help us forward. If we use just different sporadic parts of these classifications, we will not make progress. So how do we see the further development of this family of international classifications? First of all, we envision the development and introduction of new, more sophisticated versions of classifications and development of derivative classifications. So this question is still pending and open at the national level. The second point is that we expect the creation of tools that will help obtain, derive, and analyze data in real time without a significant delay when it's too late. And information technologies that we have are actually handy in doing this. They allow us to evaluate the possibility of defects that were accepted as part of specific activities. Uh, so a technology was developed for ICD-10 and it can be further applied for ICD-11. The third point is that all these tools should be integrated into a sort of a toolkit of mechanisms for decision making in public health, because sometimes you need to take a decision right on the spot, right here and now. And it's very often happens that you take such a decision and then you understand that it was wrong. This can be seen not only in Russia, but also in other countries. But still, we have some challenges that we have to tackle in order to effectively move towards sustainable development goals that we have accepted for us as vital and as needed to be achieved. Thank you. Thank you very much, Sergey. I think that we will give the floor to the next speaker.
Dmitry Mishkov will present the prospects for the development of health technology assessment in the light of the main provisions of the Sustainable Development Goals. In my speech, I would like to tell you about those issues that are connected with the assessment of the healthcare technologies and how it is connected with SDGs, rehabilitation, and functioning activity recovery of people with disabilities. Currently, we speak about goal number 3, good health and well-being. Ensuring healthy lives and promoting well-being at all ages is essential to sustainable development. Moreover, it includes the universal coverage of the health services. And when we speak about it, we have a new question about the resources allocation. The next questions that we have are the following. What do we spend and what do we receive? What are the consequences of using different healthcare technologies? What clinical consequences will we have that can be expressed via ICD and ICF terminology? What clinical results will we get? And what clinical safety will we get? Safety of different healthcare technologies. What expenses or loss or maybe reduction of the expenses will we get using different healthcare technologies? Moreover, we should take into account other social factors. In fact, we take up an issue of the complex cross-agency approach that Sergey Nikolaevich has just mentioned, and evidence-based approach that is also important and that Sergey Ivanovich spoke about in the beginning of the session. We cannot answer these questions correctly if we don't use evidence-based information, but use hopeful thinking.
We should have facts. On the basis of factual information, we can create models and develop scenario type solutions. The choice of scenario shall be relevant to economical situation and social needs. Talking about healthcare technologies evaluation, first we should keep in mind that these technologies are something that can really affect the health state. And it's not only about lost years of life or gained years of life, it is also about quality of life. Global value or added years, quality adjusted life years, all these are factors which, according to WHO, are most effective and most convenient to reflect measures taken for improving public health. Traditionally, it all is connected with a small problem of checking medicine efficiency. When calculating the costs connected with the testing and analyzing clinical results. So here we're talking about pharmaceutical economics. Of course, healthcare evaluation is much broader. It includes all actions taken in connection with diseases or changing functional status of the patient, and besides provision. So evaluating healthcare, we should enable normal people functioning, and we should have a clear definition of health, the one which was formulated by WHO. Social, physical, spiritual welfare, creating proper environment. These are all questions covered by healthcare evaluation process. The technology should be safe, economically justified, and of course, effective in the first place. Healthcare technology evaluation, as I already mentioned, is very much connected with pharmaceutical economics, where evaluation tools are more standardized. There are lots of regulations specifying the process. Future development of up-to-date tools and technologies cover not only clinical and economical aspects, but also social consequences of technology usage and bioethics issues. In order to get adequate healthcare evaluation and adequate results prediction, we need the following. First, enough information. Sergey has mentioned before that it's not only a question of information quality, but also quantity, data quantity. We need global information. Data received from all over the world we need local information from the countries having similar economical situation and social effects. When we compare countries and regions with close social structure. One more important condition of adequate technology evaluation is using the same definition basis. That already was mentioned today on various occasions. So we have to use WHO classification. It describes the absence or presence of some diagnosis. It describes changes in people's state and how adaptation to environment changes within the time of rehabilitation process, and also international classification of medical intervention, which describes, standardizes, and uses the same language when dealing with interventions. done to change patients' state. Nowadays, we face a range of challenges happening all around the globe, and we have to react somehow. This is where our healthcare evaluation helps. If you compare how much medicines cost 10, 20 years ago and how much it costs today, we can see the difference. It is obvious for every person. There is also now a category of people who need who suffer a lot of costs connected with their rehabilitation. Especially it happens when we deal with some rare diseases. There may be some hereditary diseases. So these patients have to do something with this high costs. And we cannot measure everything by money. With money, we should follow by ethics, principles, and values. In response, we got generic medicines. For countries with low and medium income, this is a real blessing because they help to reduce healthcare costs. But at the same time, this is a problem because it blocks development of new medicines, of just blocks R&D process. If we can use low-cost solutions, there is no stimulus for us to develop ourselves, to develop our own technologies and spend budget for innovations and medical solutions. And this is where we start regressing, degrading, and we can find ourselves in a situation when we don't have any innovations at all. Information we have to process to make correct decision shall be well used because there is a lot of so-called white noise, a lot of redundant data, and in all this abundance, we cannot sometimes select what we really need to make the proper decision. And the last point here is awareness. 20 years ago, when first agencies for technology evaluation appeared, we that time didn't know for sure whether we need it or not. But now we know for sure that we need it. We need this evaluation to be done, and it doesn't matter whether we talk about prevention, rehabilitation, or treatment. We need to evaluate technologies from clinical, economical, and social point of view. And then we should think about tools. In modern times, we should think about medical help availability, medical service availability. This is something we often find intuitively clear. We know always that we have some support from in terms of this, and we think that this is something that happens on its own. That social health is effectively maintained. But unfortunately, we never present real data, real statistics showing whether we progress or regress in terms of this. So today I'm going to show you some statistics. Another aspect is about questions which should be solved to make medical technologies available for the patients. The volume of information to be processed and data existing for selecting key issues allow us to deal better with the situation. We should also consider what are the future ways of technology development and what we can expect from healthcare technology evaluation in the future, how it is connected with other areas and with bioethics issues. Here you can see the connection between the number of new registered medicines for oncology treatment and reduction of medical statistics. You can see mortality rate after the first year after the diagnosis was set. We see that the more new medicines are registered, we cannot use here innovation term because it does not exist. This term is used in general, in ordinary speech. We understand what it means, that this is some new technology or medicine that provides us with some advantages. But unfortunately, we don't know what a quality advantage means. That's why we decided, instead of innovative medicine, to use the word new medicine or new technology. We see that the number of medicines developed for lung cancer is increasing, and the mortality rate at the same time is decreasing. Patients receive the access to this medicine, and as a consequence, we see that the risk or probability of quick death is decreased. The cumulative risk also drops. Patients get the chance to die of other conditions and factors, including aging. Probably this is the dream of most of us, to die of aging and not of some disease. We see here a positive trend, but on the other hand, it's not very dynamic. 10-15% mortality rate decrease is still quite considerable. The maximum mortality rate is 100%. The maximum number of medicines is also here taken as 100. And you can see on the same picture that something is growing, something is dropping. We can see here reverse correlation, Pearson correlation. That is when the more one indicator is, the less other indicators are. So increasing alternative treatment causes the decrease of mortality rate for this disease. While at the previous slide, we could see dependency in respect with cancer. Here we can see statistics on other diseases, but still the situation is the same. Whatever disease we take, we can see that there is increase of availability of medical technologies, which brings about drop of mortality rate. The very availability depends on several factors. First, presence, approval, presence on the market, I mean, then approval. It does not necessarily be coinciding. It can be that the medicine is approved, but it's absent on the market. It can be too expensive, or just there is some deficit, or it's difficult to be acquired on national level. So it depends on different factors. And one more thing is a bit usage opportunities. Today we were listening about palsy treatment, when sometimes our own perception becomes an obstacle for child rehabilitation. When the mother asks about massage in the center and she leaves the center in case there is no massage on the list, but in fact, this is not what her child really needs. So, changing the mindset of such people can really help to overcome the barriers set. Now, a couple of words about data volume necessary for decision making. Here we speak about safety and results. It's not only about medicines, but about medical technologies, also everything that is under clinical trials. We see that the number of clinical trials is increasing, and last year it was more than 300,000. It's important that clinical trials report is a very thick book, several centimeters thickness. And of course, it also should be thoroughly analyzed. We need the system, we need the structure, we need to select most important parts of it to see how data influence each other. And for the same year, we had about 40,000 systemic reviews, summing up the results of this clinical trials report. And we see that for the last 3 years, there has been a growth in 6 times of information amount. We need to be able to evaluate clinical and social consequences. And of course, here the rates now are very high. I would like to show you how one clinical recommendation is prepared, or this is some kind of a system review. We asked our colleagues to provide us a review for some months. We counted the number of system reviews and the cost of this review. I won't comment all these numbers. You can see them on the screen, and we are short of time, so let's skip it. When making decisions, we should deal better with the information. A scenario shall be done. You can see here that international classification is used to evaluate functional state, diseases, medical interventions we mentioned today. And we should know how much information we process. There are so many issues covered: finances, qualification, education, bioethics. So every time we analyze, we should run a multilateral analysis. The number of organizations responsible for healthcare technology evaluation is increasing all the time. And we see that a lot of things depend on budget in many countries. We see that countries are divided into three main categories. The first category is uh, the first category is the country where um, the income is corresponding to specific level. So we start with a low level, then we have countries with medium income level, and here we can, in comparison with the previous one, we can already see that there is not only one agency evaluating healthcare technologies, but two or three agencies. They have to solve a lot of issues, and the number of such structures and people involved increases quite fast. In the right side of the diagram, we can see some countries with very high income per capita, and they don't evaluate efficiency almost thoroughly, almost the same as in the first category, because they have too much money to be worried about how much they spend. So the second category shows most involvement in this evaluation, and first and third one lower. This diagram helps us to see a better vision of the situation. And it is not only important to remember about it when dealing with medicines, but also with the very rehabilitation process. Rehabilitation is always an investment, as one of our colleagues mentioned, and investment in rehabilitation is extremely important factor influencing ability to use these technologies. You can see on this picture the problems of countries with low GDP, and we have to overcome these problems, the challenges we face in connection with pandemics have already been discussed today, but still we should emphasize that they are becoming more important due to the pandemics, and the approaches for evaluation change. There are more requests for evaluation. You see that main technology is listed on the screen now. They are used for consequences, results, evaluation. We can see that not a single country uses only one method. A complex and multidisciplinary approach is used. Thus, one can analyze the problem from different sides. Even if we take economics only, there are also various aspects to take into account, not only about cost decrease, but also correlation between efficiency and cost and quality adjusted life years years of life gained, then the readiness to pay, you can see quite a lot of criteria. So in any case, it is a multidisciplinary approach necessary to adequately use modern scientific achievements. Without them, no effective rehabilitation can happen. The analysis shows that technology evaluation is very much connected with bioethics. On the one hand, when evaluating healthcare technology, we mostly use interdisciplinary approach. Not only interdisciplinary, but also interdivisional. One of the tools used here is already applied in practice. This is bioethics, bioethical expertise as one of the key elements when evaluating healthcare technologies. On the other hand, we have bioethics as a science dealing with interdisciplinary solutions. Bioethics is developing so that there are more and more controversies, and on the other hand, more and more publications dedicated to empiric results. We see less publications dedicated to philosophical thoughts. A consensus is achieved usually when a team of authors achieve practical results and can show what is good and what is bad. This is one of the last slides I want to share with you. It shows the result of analysis in connection with bioethics. Bioethics means moving from general to details, and if healthcare evaluation usually is vice versa, movement from details to general questions and decisions, what is good and what is bad. And these two sciences shall be aligned. Here you can see the summary. I won't read it out. I just want to say one more time how important it is to evaluate healthcare technologies.
Thank you very much, colleagues. Are there any questions, any proposals? No questions. If you have any questions about standardization, if you have any questions about classifications, we will be present here and we will be happy to answer these questions to those who are also physically present here. Thank you very much for being steady, resilient, and I think that at this point we can finish our session. Thank you very much to our technical support. Thank you very much and see you.